present a poster called The Use of Bioactive Materials in Conservative Dentistry. We are a team of doctors from Morocco, Casablanca, and we will share with you a few cases that we treated in our hospital. So the present work was prepared with the Dr. Jabrane, Professor Merini, and Professor Sidqui. So the aim of this work that to explore through clinical cases the different uses of bioactive materials in the restorative and endodontic field. So bioactive materials have been used in dentistry and the medical field, and these materials are commonly used in the field of conservative dentistry for regeneration, repair, and reconstruction. They are available in different presentation and compositions and used depending on their clinical indications, acting directly on vital tissues and inducting their healing and repair by activating stem cells through various growth factors. So we will see the three main bioactive materials that we use in a clinic. So the first one is MTA. MTA is the mineral trioxide aggregate, or commonly called Portland cement. It was introduced by Torabi Najad in the 90s, early 90s. So it's composed from dicalcium silicate, tricalcium silicate, and tricalcium aluminate, gypsum, and tetracalcium aluminoferrite. There is calcium silicate containing materials helps in apatite formation. And the exact mechanism of dental and bridge formation by MTA is not already known completely, and more research is needed and already established to understand this mechanism. So it's indicated in vital pulp therapies, resorption repair, as the sealer also, or obturating material. It's used also in apexification, apexogenesis, to correct the procedural errors and mistakes, and as well for root filling materials and apiectomy procedures and more other indications. Its main disadvantages are poor handling properties, long sitting time, presence of toxic components in the cement composition, difficult retrieval from the treated area, and post-treatment tooth discoloration. Most of its disadvantages is those already mentioned, and also its high cost. The second, the bioactive material is CaOH, which commonly called calcium dihydroxide. It's a multi-purpose agent that allows reparation, and it was introduced in 20s by Hermann. It's composed from hydroxyl ions and calcium. And its properties are alkaline pH, stopping inflammatory root resorption, and healing stimulation. It neutralizes low pH of acids, stimulates fibroblasts, stops internal resorption, and denatures root canal proteins. Donc, its indications are direct and indirect pulp capping, apexogenesis, apexification. The same indications are as the MTA. Its advantages are low thermal conductivity. It's just very inexpensive, and this is the main advantages of this material. It's easy to use and to manipulate. It's the first bactericidal, then bacteriostatic. So it acts on bacterial materials and anti-inflammatory effects, and it induces the dentinogenesis. So its disadvantages, the barrier, which is composed of osteodontin, is not always complete and porous, prone to dissolution, which would appear on a radiograph as voids in the canal. Associated with primary tooth resorption, adsorbent material dissolution leads to microbial colonization. Low compressive strength and it is easily degraded by acid etching while bounding procedure, while proceeding to bounding procedure. The third material is biodentin. Biodentin is a biodentin calcium silicate specifically designed as a dentin replacement material. It is available since 2009 and produced by the factory Septodon. It's a bioactive material that allowing differentiation, proliferation, and mineralization of the pulp cells. Most of the properties are common between the three described materials. The thing that differs is the composition. Biodentin is composed of decalcium silicate, calcium carbonate, and iron oxide, and zirconium oxide also. So it contains a liquid pipette also. It's an hydrosoluble polymer. It's indicated for the same indication as the two previous materials, the same properties, and its advantages are high purity, short setting time. It's set on in 12 minutes, and easy material handling and stability disadvantages. So its disadvantages are material high cost as MTA, delayed setting time, and irreversible applications. This is a table to record the whole, to compare the three materials. And now we will expose to you three clinical cases that was treated by the three previous materials. The first case is about operation of iatrogenical root perforation. So this is, you can see here the first radiograph, the radiological aspects before the root canal eviction, and the second radiograph after the iatrogenical root perforation. We materialized it with a file, with a hand file. The third picture is the clinical aspects of the cervical perforation. Then we proceed to the obturation of this perforation with the first biomaterial. So then we proceed to a radiological examination that showed that the complete filling and sealing of the exposed area. And then we proceed to the ceramic crown to perform a good sealing and étanchéité in the coronal area. And here is the 2 years follow-up showing a perfect bone healing regarding the lesion. The second case is about a direct pulp capping using calcium dihydroxide. The case is a deep caries lesion on anterior teeth. So while performing the excavation, we had accidental pulp exposure. Then we proceed to its capping. We cap this exposure with the previous material, which is the calcium dihydroxide. Then we proceed to coronary restoration using glasionomer cement because we cannot perform bounding agent and etching agent on this previous material to not compromise the capping. Then the case were a success. We don't have the follow-up, but it was a recent case, but it's still a success. So the third biomaterial is biodentin. So the case is about a defective or a defect in an old coronal restoration on this molar, this mandibular molar. So while the procedure, we have an accidental explosion of the pulp, like the previous case, but we choose in this case to use the biodentin as a pulp capping material, direct pulp capping material. Then we proceed to coronary restoration, and then we have 3 months follow-up that's showing that we have here the formation of, if we compare the both radiographs, we have in the second one the formation of a dentinal bridge. So now we will discuss the limits and of the three previously described biomaterial. So an ideal dental repair material should possess certain exclusive properties, such adequate adhesive ability and solubility, dimensional stability, biocompatibility, bioactivity, etc., like we showed previously. New materials claiming better performance are continuously being introduced in the market to optimize the dental care. The clinical uses of bioactive materials have increased exponentially over the years because their wide range of applicability in restorative dentistry and endodontics. The aim of this pulp, the aim of the pulp capping treatment is to maintain healthy. Sorry. Can you hear me?
Yes, yes. You have 1-2 minutes. You can conclude in front.
Thank you. So the aim of the pulp capping treatment is to maintain healthy pulp tissue by sealing the pulp against bacterial penetration and initiating a dentin bridge formation at the exposure site. The calcium ions included in calcium dihydroxide reduce capillary permeability and thus reduce the serum flow and also reduce the levels of inhibitory pyrophosphates that cause mineralization. The hydroxyl ions helps in neutralizing acid produced by osteoclasts, maintaining pH for pyrophosphatase activity, leading to increased level of calcium dependent pyrophosphatase, so which reduces the level of inhibitory pyrophosphate and helps in mineralization. So calcium dihydroxide doesn't seal the exposed pulp from external environment. The inability of this product to seal out bacteria might eventually lead to failure of the treatment. So it's not, we can conclude that it's not the material of choice in certain cases. So the MTA, the mineral trioxide aggregate, may be a good substitute, and the calcium silicate containing material in this product helps in apatite formation. So the exact mechanism, as we showed previously, the exact mechanism of dentinal bridge formation by MTA is not known completely, and more research is conducted right now and is needed for understanding this mechanism. However, it was found that this product was used as a pulp capping agent, as it induced cytological and functional changes within pulpal cells, so resulting in the formation of reparative dentin at the surface of the exposed pulp, of the exposed dental pulp. When placed, it helps in proliferation, migration, and differentiation of odontoblast-like cells that produce a collagen matrix. This unmineralized matrix is then mineralized by osteodentin initially and then by tertiary dentin formation. Due to MTA's disadvantages, biodentin was introduced as a restorative material and has recently been proposed for direct pulp capping. It has been recognized that the first all-in-one bioactive and biocompatible material. So this is the dream biomaterial, if you permit, for damaged dentin replacement, but it's not lacking of disadvantages also. Studies showed that pulps that were treated with biodentin were essentially free of inflammation and led to the formation of a good quality of bridge, dentinal bridge, which was more predictable, uniform, thick, continuous, and completely sealed the pulp tissue in comparison to calcium hydroxide. Due to lack of long-term observational studies, it is difficult to infer concretely that which material out of MTA of biodentin is superior. However, maneuverability and economical factors fall in favor of biodentin because its cost is less than MTA. So as a conclusion, we can say that the clinical uses of bioactive materials have increased exponentially over the years because of their wide range of applicability in restorative dentistry and endodontics. MTA and biodentin are comparable and may score better than calcium hydroxide as a capping material. Nonetheless, more studies are needed about the materials and their longevity and substantivity. Likewise, bioactive materials increase life expectancy and social obligations in order to provide a better quality of life. So I can leave you with the references used to produce this manuscript. And thank you very much for letting us participate in this valuable event and greetings from Morocco. Thank you.